Coral.
Hello.
Give it another minute or so as people are filing in. And then Dr. Dunietz is doing the first part, correct?
Yes.
Hi, Galit.
Hi, how are you?
Good, how are you?
I'm good, thank you.
Good. Yeah, it looks like we got some people logging on right now, and then after that, whenever you want to get started, go ahead.
Okay, so I think I will start with my brief presentation and then Coral will take over and present the paper. Is this okay?
Perfect.
Great. So let me share my screen. And then I need to go to presenter mode. Yeah, okay. Presentation mode. Can everybody see this?
We can see the whole slide deck.
You
Like on the
don't?
side. We see
Oh.
the sides on the side as well, but we can see it. There you go.
Is this okay now? Do you just see one slide now?
Exactly.
Okay, great. Okay. So welcome everyone. Today I'm going to be presenting on t-test and chi-squares, and this is part of our series that is called Critical Appraisal through Journal Club and Research. So what are t-tests and chi-squares? They're both simple statistical tests that are used in descriptive tables of most papers that you will read. And the descriptive tables are usually table 1 and 2 that provides differences in demographics or other key risk factors, excuse me. So the differences between t-test and chi-square is that t-test is used when we are comparing or dealing with continuous data, and chi-square is when we look at dichotomous data, and I will explain soon what I'm talking about. So, excuse me. Something is wrong with my slides. Okay, so the t-test. So when we're dealing with independent samples, we're comparing means of two continuous variables in two independent samples. And when I say independent, that means that there are two different groups of people that are not related to one another. So if we're comparing women and men, or we're comparing whites and non-whites. And what we're interested in is whether there's difference between the mean of a certain variable that we are measuring. An example is that when you look at blood pressure, we want to compare whether people who sleep less than 7 hours have the same systolic blood pressure as people who sleep at least 7 hours. So what we're doing here is we're calculating the mean blood pressure for the short sleeper and compare it to the mean of the blood pressure of those who sleep at least 7 hours. So are these independent groups? I encourage responses and interaction if possible. What do you think? Are these independent groups, the short sleepers and the normal/long sleepers? Okay, so I will answer. This could be independent groups if we're measuring at the same time two different groups of people. It could be the same person. You can look at the blood pressure of the same person before when they have shorter sleep and compare it to a night that a person had at least 7 hours of sleep. So in this case, it is independent. So let's assume that they calculated the mean for each of the groups and they found out that the difference is 12.7 millimeter mercury. So the first question that we ask as clinicians, we want to know whether this difference is clinically significant. And if it is clinically significant, it should not be dependent on whether it is statistically significant. These are two different questions that we ask ourselves. How do we test if the difference is statistically significant? So for that, we use, do you see my new slide?
We see the slide on t-test.
Okay, I don't know what's going on.
Yeah,
Maybe.
it looks like it's getting superimposed.
Yeah, maybe it's the connection. Okay, so let me stop sharing. And try again. Do you see my screen now?
Yeah, t-test independent samples, t-test.
Okay, so I'm going to get out of this presentation mode. Okay, so so the statistical significance is different than the clinical significance. And what we are trying to do is compute a test statistic to examine whether it is a significant difference between the two groups. How do we do that? We calculate the first mean of the first group, the short sleepers, and we compare it to the long sleepers or normal sleepers, and then we divide it by the variance in each of those groups and accounting for a sample size. Because the groups could be similar, but the groups could have a different sample size. So this is the test statistic. I don't expect that you know how to calculate it, but at least you know what goes into generating a test statistic when you look at differences in means of continuous outcomes. Okay, so now how do we know if it is, in fact, now that we have the test statistic, how do we know if it's significant or not? The test statistic corresponds to a probability, and this probability is then compared to our alpha of 0.05. If the corresponding probability of the test statistics is larger than 0.05, then this is not statistically significant. If it's lower or smaller than 0.05, then it is statistically significant. What we need to keep in mind here is that we're dealing with continuous means of two groups. The groups are completely independent, and we're also assuming normal distribution of the blood pressure. For example, if this is the outcome, for a small sample size, if our sample size is greater than 30, that's the convention. If it's greater than 30, then we assume normality. And if it's not more normal, then we have a different test to examine whether the differences in means are significant, but it's not the t-test. Okay, so here we're comparing means, but we have samples that are dependent. So as I said before, independent means that the two samples are unrelated to one another, but dependent means that we're talking about the same samples and there's an intervention involved or something that happened to the sample before and after our measurement. So there's a time one measurement and there's a time two measurement of the same people. Here's some examples. We look at blood pressure before and after medication use. And the blood pressure is, again, we're comparing means before and after the medications, or we're looking at hypnea-hypopnea index before and after weight loss program. So this is when we're using dependent samples because it's the same person before and after a certain intervention. So let's look at this example of AHI before and after weight loss. These are not independent samples, as I said, so there's a different formula for the test statistic. Instead of comparing differences between two means of two samples, we're looking at the mean difference between AHI at time 1 and then AHI at time 2. So instead of differences between the means, we're looking at mean differences. And then there's a different test statistic. It's also accounting for the standard deviation and the sample size. And the standard deviation is different here because we're talking about the same people, so it's going to be less variability. Okay, so this is when we're talking about two groups. What happens if we have more than two groups? So instead of using the t-test, we're using ANOVA. And here, we're assuming that there's at least 3 groups or more. So the comparison is being done of means across 3 or more groups. So example regarding sleep duration, before that we had a binary, we had less than 7 or 7 and more. Here we have the short sleepers, we have the normal sleepers, and we have the long sleepers. So these are 3 categories. And what we're doing is we're comparing the blood pressure for each of those 3 groups. And we're doing that using ANOVA. So this is a cheat sheet for the type of analysis for continuous data. So what we have here is that if we have an independent variable, we're using a t-test for comparing means of 2 groups. And if the groups are independent, if not, then we're using a paired t-test. A chi-square is examining associations between 2 categorical variables. And it's also called the test of independence because what we're trying to understand whether the 2 variables are related to one another or not. And what we're doing here is we're not comparing means, we're comparing proportions. So how is chi-square different than t-test? Here we have more than 2 groups while the t-test has 2 groups. And here we're dealing with categorical variables, not continuous, and we're comparing proportions and not means. So I hope that this is clear to explain when we're using and why we're using each. And here's an example. If we're interested to examine the prevalence of hypertension, whether it's higher in people with OSA versus people without OSA, so we have here 2 variables. We have the hypertension, and we'll classify patients into 2 groups, yes or no. And then we have sleep apnea, and we also classify them into 2 groups, yes or no. We can alternatively create more than 2 groups for OSA and use 4 groups for normal, mild, moderate, severe. It is dependent in our sample size. So everything that we're trying to do with a chi-square can be summarized in a 2x2 table. And these tables are so useful for calculating different measures of interest. For example, we can calculate odds ratios with these, we can calculate relative risk, sensitivity, specificity, and all kinds of testing. They're very, very useful way and provides a lot of information. So in this table, you see that we have 4 groups. We have the groups with no hypertension and OSA, no hypertension, no OSA, and then the other 2 groups that has both or has none. So this is an example for when a chi-square test was used to examine whether hypertension is higher in people with OSA versus non-OSA. So this is a binary outcome here, the OSA. And you're seeing that we're comparing here not the 125 and 29, which is the sample size, but we're comparing the proportion, which is 72% with 54%. And what we're seeing here in the p-value, that there is a significant relationship between OSA and hypertension. Okay, so this is how the test statistic for chi-square looks like. And basically what we're doing is for each observation, we compare the observed value with the expected value what did we see in the sample and what was the expectation? And then we divide it with the expected value. And we summarize these differences for every observation in the sample. And so the larger that the chi-square test is, the more likely is that the test statistic will be significant. And of course, we get a test statistic from the chi-square, and then we compare, we look at the corresponding probability of this test statistic and compare it again to the alpha of 0.05. Okay, so chi-square is sensitive to sample size. When we have those 2x2 tables or 2x n tables, we need to make sure that we have at least 5 observations in each cell. This is for a 2x2 table, but if we have larger tables, we have more than 2 categories. We need to have greater than 5 in at least 80% of the cells. And sometimes we have situations when we have cells with zeros. We have nobody who doesn't have OSA and doesn't have hypertension. If you're looking at older adults and at-risk populations, you will have sample ample sample sizes in each of the cells. But sometimes when you look at low-risk groups, you find zeros in some cells. And so what do? You can't use chi-square test. There's a different test that you can use when you have zeros in those cells. So these are independent samples, the chi-square. If you have dependent samples, then you use a McNamara chi-square test that accounts for the variability that is different independent versus independent, and also accounts for the sample sizes. So an example of dependent chi-square is when you want to compare a proportion of OSA patients with hypertension before and after initiation of CPAP. And this is another cheat sheet for chi-square when you have an independent and you use the regular chi-square test, and when you have dependent variables, use the McNamara chi-square test, which are different formulas. Okay, so these are 2 common, simple statistical tests that we use to describe data. And before I leave, I want to ask you a question. What do you think about the results of these comparisons of differences using t-test and chi-squares? Do you think that we can report them? Do you think that they have any limitations? Anyone?
I think you gotta, sorry, I think you gotta report, the findings, but of course, you gotta recognize that there are limitations for this. I mean, you're just comparing, one magnitude versus the other one, but you may need to adjust, the analysis for other, variables.
Absolutely. So, perfect. These comparisons and the results that we get may be confounded. It may be confounded by sex, it may be confounded by socioeconomic status. There's a lot of confounders that can affect these results, and we cannot. This is why it's table 1 and 2 and not table 3 and 4. Table 3 and 4 are supposed to be adjusting for these things, and we cannot take those results seriously before we look or we examine any potential confounding. And this is the end for me. And now I will let Coral take over.
Gotta unmute myself first. Okay, I'll share my screen. Can you see my PowerPoint?
We can.
Awesome, thank you. So, hey everyone. For those who don't know me, I'm Coral. I'm one of the Sleep Fellows. And for the January Journal Club, I picked this article here regarding cethiamine. So for disclosure, I have no disclosures. So this is the article that I chose, and it's a tertiary exploratory analysis of an original study. So as a tertiary exploratory analysis, it's technically a subset of the original study, And just as a background of the original study, which this article did briefly discuss. So the original study was completed in 2021, published in 2022. It was completed in Sweden and it looked into cethiamine. So as a disclaimer, cethiamine apparently is not used in the US of A. It's actually an antileptic medication used in Europe. But because of the carbonic anhydrase inhibitor mechanism of action, it was studied because of the similar studies that were previously done on other CA inhibitors such as acetazolamide. So based on the original study, which was a 4-week double-blind randomized trial, they looked into that and they also did a dose-based trial with the placebo 200 milligrams, 400 milligrams. Based on that study, they noted that, hey, cethiamine can treat obstructive sleep apnea. And then they collected a bunch of data from that. And then from that original study, they then broke it down into other sets of studies to analyze. So for this particular article, I bring this up because even though this medication isn't in the US of A, this article was actually sent to me by a lot of my previous PCP family medicine colleagues, because apparently their patient used Dr. Google and then have found lots of searching other ways of treating their sleep apnea with medication, especially with the recent Zepbound approval. So if patients are able to access all this, I was curious on how this medication could potentially affect future management of OSA. And this medication was also brought into discussion during the 2024 CHEST meeting, as well as the American Thoracic Society at the international conference this year. So with this study, subset of the original study, they focused more on the CA activity as well as the HIF-1 alpha biomarkers, because those markers were noted to be elevated in obstructive sleep apnea. And then they wanted to investigate how this medication as a CA inhibitor would affect it in treating obstructive sleep apnea. So just as a background for HIF-1 alpha, this is a transcription factor that helps the cell know how to respond to changes in the oxygen levels. So during obstructive sleep apnea, such as at apnea events, it helps to increase the oxygen delivery. For the carbonic anhydrase component, this is the enzyme that catalyzes the conversion of carbon dioxide and water to bicarbonate protons. So in CA inhibitors, how they affect OSA isn't necessarily like what HAP therapy necessarily does with the physical airway collapsibility, but rather the breathing stimulation and ventilator control sensitivity. So with cethiamine, the fact that it hopefully is based on its mechanism as a CA inhibitor, what do we predict that how it will affect the HIF-1 alpha and CA? Will it decrease or increase these biomarkers for the fellows? For anyone who wants to answer.
Doesn't it decrease?
Yes, decrease. So thank you, Omar. So for the HIF, it'll decrease this biomarker as well as the carbonic anhydrase. And then knowing that the cethiamine affects the metabolic component with CO2, what component of that we previously discussed about OSA would this affect symptomatically? Probably my question is that. So it's basically, it'll affect loop gain. So can anyone explain what loop gain is?
Yeah, so loop gain is essentially it's a mechanism to describe how ventilation works. So it's controlled by 3 different mechanisms. It's the mixed gain, the loop gain, and the plantar gain. And so essentially the idea is plantar gain is the chemical and plant gain is the receptor that responds to that chemical, and the mixed gain is how the lungs respond to that response from the receptor.
Awesome, thank you, Alma. So then with the breakdown of loop gain and its different components, what subtype of loop gain would be affected by sulfathiamine or CA inhibitors? Since CA inhibitors such as sulfathiamine affects the CO2 component of OSA. Okay, cricket. Okay, plant gain. So just like Yama explained, these are the three breakdowns for loop gain. And then sulfathiamine will likely be impacting the plant gain component of this in respects to OSA treatment. So going into this article, the study initially focused on basically three groups of the medication: the placebo, 200 milligrams and 400 milligrams. And then they did a total of 3 visits. So there was a baseline visit, where they did also the blood draws as well as a baseline PSG. And then they did a follow-up visit afterwards, followed up for, I think it was 3 weeks. And then they implemented the medication and then up titrate the medication and then maintained them for about 4 weeks, with the final visit after the 4 weeks where they did the blood draws and then a repeat baseline, repeat PSG to assess how their obstructive sleep apnea changed. And then with this study, they only included severe sleep apneas reportedly. So with this sample of a subtype from the original study, what is exactly a tertiary exploratory analysis?
I think it's used to like create new hypothesis, but I
Yep.
don't remember exactly what it.
No,
Yeah.
exactly. Yeah, thanks, Summer. So yeah, a tertiary exploratory analysis, I was interested because I never heard of this before. So exactly right. So it's basically different from a randomized. So you never go into the analysis with a specific question in mind. You basically reflect back. You kind of look back on a randomized control trial to see if there's any or identify any potential new research or things that should be investigated more, like looking into different aspects of the original study to see if there were any patterns for future research. So that's also why it is also important to look into, especially as subsets of the original study, because the original study will kind of open up a finding, and then from there they can branch out to see like, oh, what other aspects of, in this case, this medication could affect obstructive sleep apnea in various ways. So exactly. And then because of that, we do have to question how reliable the conclusions are made in these particular articles, just because how they're interpreted, and then they weren't pre-planned. So you have to question the reliability of the results of these particular studies. And then since we read the article, what do you guys think about the inclusion and exclusion criteria for the study?
I thought that the inclusion criteria was very specific. For example, they wanted moderate to severe OSA, which is understandable. We would see more hypoxemia with that, but also the BMI criteria. They had a BMI criteria, which I was surprised by. And then for the exclusion, I remember seeing that they excluded severe nocturnal hypoxemia, like more than 10 events. And I believe it was less than 50%. I mean, I don't
Yeah.
remember.
Nope, that's exactly right. Yep.
Yeah, as well as hypertension, which seems like all of our studies so far have excluded hypertension patients.
Definitely.
Also,
Any, oh yeah,
didn't ever exclude if the blood pressure medication was changed like within like 4 weeks or something like that. I was
Yep.
just curious like why they would have done that. Is it
so I looked into, like, that's another thought, like, I think that was a good thinking on their part, just because it could limit other like variables that could impact the study, and especially like inflammatory factors, and there's variables that are unchanged. But I also like read through the original article. They didn't really specify like a specific reasoning, but I do think it was a reasonable exclusion criteria. That way they can keep everything more constant. Now, later on, I'm gonna ask like, hey, could that also limit, because is it actually reflective of how our patients are really? Because even yesterday, I had a patient come with a blood pressure 170 systolic. So it kind of questions on how applicable the criteria was for the actual real life setting. How did you guys think of the BMI? Because I think it had to be greater than 20, but less than 35 BMI.
pretty wide range, no? Like 20 to 35.
Definitely. And I think the age range, even though it was 18 to 75, the mean actually was around like the middle age portion too. Um, any other thoughts on the inclusion exclusion criteria? Do you feel like there's other aspects that they should have considered, or they were too specific, like they included too much criteria?
Doesn't the BMI at 35 doesn't that cut off like a lot of our patients?
Totally agree. Yes. Thank you, Dr. Matlin. I totally agree. It's definitely not reflective of a lot of our clinical patients, especially with severe sleep apnea too.
I had a question. Like
Yeah.
I noticed, maybe I missed it in the article, but did they exclude anyone with like COPD or any lung issues?
So they did not mention like COPD specifically, but they did mention central sleep apnea, Cheyne-Stokes breathing, and the O2 DSAP, but they did not mention specifically like other pulmonary disease processes. Not that I found.
Got it.
Good question though. So this is the chart that was included in the article. So I stared at this for a while. Did anyone else find this breakdown interesting?
It doesn't seem like an even breakdown.
Agreed. Yeah, because when I can see where it makes sense up to, I don't know if you can see my mouse or not, like up to this upper part portion. But then once it starts breaking down here, I honestly, I got lost, and I even tried looking back at the original article, which didn't, they just stopped here because that's what the original article completed their study at. So the subset here, they broke it down further. It doesn't add up. So like the CA activity, if I add it up, it's around like 43. And then the HIF, one alpha concentration, adds up to 53. Anyone have any thoughts of what may have happened here?
It mentions only participants with complete data on one or the other were included in the analysis in the end.
Yeah.
So if
So
they didn't have complete, they didn't include them in the end.
agreed. And then another question came up is, even if they did exclude like a person who did not have blood draws in like complete blood draws, it still wouldn't, it would seem to, like, I would have thought it would be less rather than higher. So I'm thinking, could there have been like an overlap? Like there are patients who were only in the CA activity, and then there's a couple with like got data for both, but they all completed the blood draw the 3 times during, I mean, the 2 times during the visit. So I honestly don't understand the breakdown of the sample size for this one. Any other insights or thoughts? Because I could not figure it out. And I even talked to Dr. Dunietz with it or regarding it as well. So moving forward, this is the data summary for all the different cohorts, and then I highlighted the different breakdowns that really stood out to me. Did anyone have any thoughts regarding the different cohort and everything that was looked into regarding them?
So, Coral, the numbers don't really, may not even reflect clinical significance if basically looking at, let's say, placebo versus treatment groups, and the AHI is like essentially close to each other with a giant standard deviation that they go into each other regardless. So this also includes all the other values to a certain degree as well.
Yeah, I agree with
Agreed.
you, Isaac.
Mhm.
Meaning like they may have found some statistical significance, but not clinical.
Definitely. How about the difference between male and female patients in the sample size?
It was more males than females in both the full cohort and the placebo.
Definitely agreed.
Mm-hmm.
And then kind of relating that to the age, I don't know if the age was also comparable between male and female population too. And plus, like what Farouz said, definitely a male predominance in this study. What did you guys think about the weight? And then just so you know, 85 kilograms is 187 pounds. So if you do the standard deviation that they use, the patients range between 158 pounds to 216 pounds. Do you feel like that's reflective of what of our patients in clinic?
Isn't the average weight in America like 200 pounds? Like average in men, I think. I just Googled it. So,
Oh,
but
thanks,
in like
Nora.
in our clinic, it's yeah, like we see mostly over like probably 200 for the most part.
Yep. Yeah. Any other thoughts of this data set?
Coral, there's some comments in the chat as well. I don't know
Oh,
if you're able
sorry,
to
I
see
can't
that.
see.
No, you're good.
so-
Do you want me to read them?
Yes, please.
Yeah, okay, from Dr. Vijay Kumar, no difference in CA activity or HIF1, team placebo and treatment. And from Dr. Matlin, depends on the height.
No, I was just responding to like the weight would, yeah, but more
Oh,
just
gosh,
like I
thank
use BMI over weight because like if you have a short person that's, almost 200 pounds, it's different than a taller one.
Definitely. I do wish that, like, I know the BMI is there, but I also do wish the height was listed as well, pointing to what Dr. Matlin mentioned too.
There's some more comments. Europe is usually lower BMI compared to the US, and average BMI in the US is 29.
Oh, good facts to know, definitely. So then kind of going into the study a bit more, they did mention that the biomarkers were drawn at a specific time. did anyone have any thoughts about how that may affect the data collection for HIF, 1 alpha and CA? So the blood samples were collected the morning of the baseline study as well as the follow-up study at the very end. Do you think the timing of the oxygen draw would affect the blood draw would affect the data collected in general?
It probably does, since it's right after they woke up or around that time.
Yep. So they did go in depth in this discussion. There has been some articles that show there's no big difference. However, we also have to question, like during the time of day with the O2 saturation, that could also be variable if it'll affect these biomarkers as well. So definitely. And then for the polysomnogram component, did you guys feel like the criteria on how they define apnea events, sleep apnea events were appropriate?
They were completely different than what we use. I think even Dr. Gavidia mentioned it in the chat, but like hypopnea decrements were supposed to be 50%, where we often use the 30 and the 90, depending on hypopnea and apnea.
Agreed.
And also their definition for moderate sleep apnea was different. It's like HA greater than 10 in the study.
Yes. Any other
There's a
thoughts?
comment that these
Oh,
are
yeah.
old criteria being used, old ASM criteria.
Mhm. Awesome. Thank you, everyone. So in the end, with sulfamine, they did notice the biomarker decreases with the treatment, but they also noticed the AHI with these changes. So they did show improvement compared to the placebo, and then the O2 saturation is improved by 1%. But my main question is, do you feel like this is clinically significant for implementation in the clinical setting based on the data that we got?
The raw data has such a big standard deviation. I know they have this as the lower end comparison, but like looking at the raw data with their standard deviation, there maybe no difference. This might just be like, and then the sample size is really small. So how can you justify saying that this actually had a good increase with just, you know, 7 or 24 sample size?
Definitely. The sample size was very limited. Any other thoughts on the AHI? Like it did drop, by 20 events. Do you feel like it's a good treatment option for OSA?
It reduces the severity, but
Another question that could potentially pop up is if this is just causing a diuretic effect and it's just causing them to be more dry, like, is that a potential reason on why this is having some effect?
Yeah, like the fluid shift.
Yeah.
Definitely something to consider. Awesome. So then, in general, we kind of already discussed the limitations of this study, the sample size, the population predominance, weight, the overall data presentation. And then we kind of also addressed the clinical aspects of applying this medication. So with this, if this medication was in the US of A, would you be comfortable starting prescription if it were to be approved today? Or what other aspects would you consider evaluating than what this article says to have been a significant finding for treating obstructive sleep apnea?
I would say a different endpoint. Values, like a lot of times we go based on how their symptoms are, and their endpoint is more values, and there's no answer on did their symptom, like their, let's say if they had daytime symptoms, that improved or not.
Agreed. And then even, I think the Epworth score needed to be at least a 6. And then I could not find if they evaluated the Epworth again. So to your point, Isaac, I don't know if they had any clinical like symptom change versus what the biomarker is, what the AHI showed. So agreed.
I have a comment. This is a tertiary type of analysis, right? This is more exploratory. And then this is more like just, they're kind of just fishing for potential hypothesis to test. So as you can see, the analysis is very simple. So it's just, t-tests and more kind of, let's say, a specific kind of comparison between, like 2 or 3 different samples here and there, and just correlation. So we don't have a full statistical model here, like adjusting for different things. So as you can see, for example, there are people in one group who had like 75% of hypertension versus other groups that have like 10%, and so many different things that were kind of unbalanced. So this is something that definitely maybe somehow perhaps explaining some of the or may conditioned in other results. So definitely that's a huge limitation. Again, the authors were clear about the exploratory nature of the analysis, but definitely this is something that needs to be, I mean, before even considering the possibility for treatment, they need to conduct like a separate trial, I will say, with more power and controlling for all those variables to kind of see if this is something more meaningful. Because I mean, it is really interesting to see that someone goes from potentially from 55 to 30. So I guess I mean you're cutting at least 40% of their AHI, the severity of their AHI. But again, is it reproducible or not? Is there something else that might be explaining that? Is there any variability from day to day? I mean, I know that they did the 2 days PSG, but there are so many different things going on here, so it's just hard to just to give the age to one or other thing.
Yeah, thank you, Dr. Vidya. Definitely agree. And it's also all the points that everyone has brought up is important because there are actually news articles that were out. I Googled it. I also Dr. Googled it because I was curious on how these patients actually got these articles. And then my colleagues from residency training, they like forwarded me this article. So apparently there were news articles that were advertising sulfamine as treatment for obstructive sleep apnea. And that's why I quoted it in this beginning slide. So it kind of gives us like a false message to the general public regarding this medication. So it is important to further analyze the limitations of these types of studies, especially if it's not pre-planned. There's a lot of different other variables that need to be considered and evaluated in the future too. So definitely. And then in general, with medication being the topic here with like Zepbound and then potentially other investigational medication with OSA treatment, what are our thoughts on medication versus PAP therapy, and as well as like the effectiveness for clinical practice in our patients, even safety wise too?
I would say a lot of these studies probably need to, instead of more of a severity reduction, should actually have a different endpoints, which should just be like quality of life or like symptoms, or because a lot of times these patients come to us because of a symptom. Like sometimes it's like very straightforward, like sleepiness or fatigue, but like some of them come with like high blood pressure, like diabetes or obesity. But like the question is like there should be a different endpoint recording like quality of life or longevity, like of treatments, or there's a lot of other things that they could actually put in that may have more, I would say, fruitful efforts on like what's a patient would consider like significant to them.
Definitely. There's definitely other aspects to patient care. Not just numbers that we see, but also what the patient needs as a whole.
There are
Any
also
other
a few
thoughts?
comments in the chat.
Oh,
I don't
awesome.
know if
Thank you.
people want to unmute and share their comments.
Sorry, I can't see. Appreciate it.
It's one from Lisa Matlin and one from Montita.
Oh, I don't know. I mean, mine was, I don't know if mine's worth really talking about, but like, and this could be just my rudimentary understanding, but when I think about like a medication and a dose effect, I would usually like to see something a little more linear than like a barely difference between two doses for it to be more convincing. I don't know if that's even like worth taking, you know, analyzing in this paper at all in general, if that's not even a good way to go about it.
Yeah, that's a good point too, because I was thinking of that aspect when I first read this particular article. So then I went into the original randomized control, and then they had more breakdown on the specific dosing, because they had a I think a what did they call, like a data analysis safety group to make sure that the dosing wise was appropriate, because initially they had planned to go all the way up to 1,000 milligrams. But then based on the data that they were collecting lab wise, as well as patient symptom wise, they ended up stopping at the 400 mark. So to your point, Dr. Manley, I totally agree. I would be interested to see how other aspects of the dosing that they'll be able to further investigate down the road if they decide to continue to pursue this.
Sure. Yeah. And whether like logarithmic might be a better
Oh,
model.
yeah.
But yeah.
Definitely.
Yeah, and then I think in the past a few years, like OSA tried to find the phenotype of the OSA, like especially in adult one. So I'm not sure that if we could, this one we attack on the high loop gains patients, but I'm not sure like how that we could like specifically identify this phenotype accurately, and then we shoot this treatment for the one that have this phenotype, because it seemed to be from the inclusion criteria. It doesn't pay attention on the phenotype of the OSA, but like choose like umbrella-ly. So, but at least we see a little bit, but like every other attendings are an input about the designs. Yeah, but I feel like it's maybe benefit if we can find the phenotype and then can have the specific treatment.
Definitely. And I'm actually glad you brought that up, Dr. Vikram, because they actually also came out with another subset study that specifically looked into the phenotype as well as the ventilatory drive component too. So that's a separate article that they also came out based on this original study. Any other comments?
Looks like there's one from Nita as well.
Yeah, often used in central sleep apnea as a treatment for somebody who don't have any effective treatment with the CPAP. Like other carbonic anhydrase, not this particular one. Usually like acetazolamide, those kind of medications.
Yes, definitely. And then to that point, I also found interesting how they excluded patients with central sleep apnea for this study. Yep. And then a last question that I was interested in discuss with these medications. I mean, with like sulfamine being an anti-epileptic medication, Zepbound being the diabetic medication, what are our thoughts on like the management with prescribing it versus managing it in the long term? Because it's gonna affect obstructive sleep apnea, but it's also likely going to affect other components of the human body. So would it be more like a multidisciplinary approach, or would it be more, oh, initiation and then someone else takes over? What is everyone's thoughts with just ongoing in the future?
In terms of like the GLP-1 agonists, some of the complaints, at least I'm seeing from like Europe, since is a lot of gastroparesis that develops with some patients, that they eventually stop the medication and it persists. It's like a potential issue for the future. It's also a lifelong drug. Most patients, they already have it on Ozempic, a study, where if they stop the medication, they already gained in within a year like 66% of their weight back, which if they recorded it longer, maybe close to 100% for some people, possibly. So it doesn't necessarily replace therapy, like alternative therapies.
Agreed.
So yesterday, actually, me and Nisha saw a patient who asked about Zepbound. I'm curious to see what's other people's thought as well. But my understanding is that if the patient meets the criteria, since it's FDA approved, we can advocate for this patient to be started on this medication. However, since this is a weekly injection medication that needs like close monitoring of both effect and adverse effect and potential dose changes, I think once we started, I would prefer to defer that to the primary care doctor who can actually have closer follow-up with the patient. I'd like to hear from what other people thought as well.
Yeah, I think you raise a great point. I don't know how a primary care provider would feel about a specialist initiating a drug and then deferring the management to the PCP. I don't, we don't typically do that for the other drugs that we prescribe. So, and I wonder what effect that would have on the patient and their adherence and things like that too, without a dedicated care pathway kind of establishing those roles. So I think you raise a good point just about what our role is in the prescription and long-term management of these drugs, but I imagine that would pose some challenges for us to just initiate the prescription, but delegate the management to another clinic.
Yeah, I think that's a very good point. I actually had, just like anybody else, I guess, tons and tons of people requesting, to start to Zepbound. And I was initially kind of tempted to kind of send them, to primary care, but then just like Anita mentioned, so this is something that has been approved for the treatment of sleep apnea, although we know that it's more like for, weight loss related for the effect. But then I guess at some point we need to start to be more proactive for that matter and take over and get more, familiar with this type of medications, because more and more people will be, asking for them. And yeah, I think we need to perhaps, start to be, to educate ourselves about these medications and to be more familiar to actually offer this to the patients, because as Anita mentioned, so they're gonna look for that because of the treatment of the sleep apnea. For example, I had a patient who told me, I told the patient, you know what, just go back and talk to this, with your primary care physician. And then he was like, you know what, we already did that. We submitted the paperwork and I was denied because of the obesity. And now that I have the sleep apnea, just because you are my sleep doctor, I'm asking you to do this for me so I can actually potentially benefit from getting the treatment that may potentially help me not only with the sleep apnea, but also with my other comorbidities. And I think that's a fair point, right? So I think at some point I know that it's going to be perhaps like a more work for us, but honestly, I think we need to perhaps evolve for that matter.
I actually agree with you. I had a patient with very similar findings today. I mean, she was obese. Ozempic wasn't covered by her insurance. And so essentially she's been paying out of pocket $400+ a month. And we were talking about it and I said, it's now approved for OSA and so on. And I think it's very, like Dr. Anita had said, it's not really best practice that we start a medication and send someone back to their primary care. I feel like primary care is already overwhelmed. I think that possibly we can make some like a CME or attend some lectures regarding medication, side effects, prescribing, all that information and get really familiar with it. I know it's an extra step that we have to take, but I don't think it's a big step. I don't find it to be, it won't be necessarily very cumbersome. Just my thoughts. I think that we just need a little more education about the side effects, how to dose it, you know, things that we have to look for. I mean, just a few extra labs here and there, or possibly a little bit of refills here and there, I don't think is much of a problem. And I think it will set us apart from other institutes in the sense that, you know, we're ahead of the game. We're already, you know, instituting and helping patients get medications that just got FDA approved last month. So I just feel like it will set us apart, and it will, you know, have patients more willing and wanting to come follow up with us and so on. So I think that's helpful.
Thanks. And there's Isaac, did you want to share your comment as well?
There's people that get it sent to Canadian Pharmacy. I knew this from when I was back in California even last year. This was before it was even approved for OSA. A lot of people wanted to use it for weight loss. This is back when Ozempic was more prevalent compared to Zepbound or Mounjaro. So they get it sent to the Canadian Pharmacy, and then the Canadian Pharmacy mails it to you. And they pay out of pocket. It's still on the expensive side, but way cheaper than the United States price.
Yeah, thanks, Lisa. I know we had Dr. Crafson come last year and give a talk about these medications. I think our schedule's full this year, but I just texted the fellows if anyone's looking for a year-end Grand Rounds topic, that would be a great topic. And certainly, I think there'll be more coming from the AASM about this as well once the approval went through. So there should be more available from them. But I think certainly, you know, as we look to plan future conference schedules, can definitely incorporate this as well. I think there was also a speaker from the September course, the September CME course, I think on this too. I think we had an endocrinologist speak there.
Awesome. Thank you so much, everyone. Any other questions, concerns? I know it's 2.
Great presentation and great discussion afterwards. Well done.
Awesome. Thank you, everyone. Bye.